Hello friends, let us now learn some important points about neuroblastoma. Neuroblastoma arises from neural crest cells. Where does this arise? It arises from neural crest cells. Then it can originate anywhere. It can originate anywhere along the sympathetic chain. It can originate anywhere along the sympathetic chain. So what is the most common site? Most common site is this neuroblastoma is present in adrenal, or it is present in paravertebral retroperitoneum. Okay, then it may be present after, or it can be present post mediastinal area, or it can be present after pelvis, in pelvis, followed by cervical area. What is the most common? So this neuroblastoma is actually the most common tumor diagnosed in infants less than 1 year of age. It is also the most common intra-abdominal. It is the most common intra-abdominal malignancy in children. It is the most common intra-abdominal malignancy in children. Okay, now this neuroblastoma has spontaneous regression. It can undergo spontaneous regression. So if you see the clinical features of neuroblastoma is here. It is the most common presentation. You will see presence of fixed lobular mass which is extending. It presents has a fixed lobular mass extending from flank towards the midline of abdomen. It is a fixed lobular mass extending from the flank towards the midline of abdomen. Then the peak incidence, if you see, the peak incidence of neuroblastoma is around 2 years of age. Most commonly it occurs before 4 years of age. Peak incidence at 2 years of age. Around 60 to 70% have metastasis at the time of diagnosis. Metastasis is present at the time of diagnosis itself in almost 60 to 70%. So what are the metastasis? So these metastasis you can see it in orbital metastasis can be seen. Okay, orbital metastasis, if you see, this is periorbital. In orbital ecchymosis we have periorbital ecchymosis, plus we have proptosis, plus there is raccoon eyes are present. Okay, then we have something called as stage 4S. In stage 4S there will be cutaneous metastasis. Cutaneous metastasis in stage 4S, which is called as blueberry muffin tumor. This is called as blueberry muffin lesions. Okay, then we have the patient will also have unusual, there is a paraneoplastic manifestation. Because of the paraneoplastic manifestation, that is, these neuroblastomas will produce VIP, that is vasoactive intestinal peptide. Thus it results in chronic watery diarrhea in the children. Okay, and the patient will also have opsoclonus and myoclonus. What is this opsoclonus and myoclonus? This is, the baby will have dancing eyes. The eyes will just move like as though like nystagmus. Just like nystagmus, it also the patient will move, eyes will move, which is called as dancing eyes and dancing feet. He will have myoclonic manifestations, myoclonus manifestations. Then what is the most common site of metastasis in older children? The most common site of metastasis in older children, if you see, it is long bones. It is long bones. Okay, in the skull the metastasis occurs in the sphenoid region. And if you see in infants the metastasis is actually confined to liver and subcutaneous tissue. Okay, and then if you see metastasis in the lungs, lung metastasis is rare. Okay, next if you see laboratory investigations, you will see presence of anemia, you will see presence of thrombocytosis manifestations, increased LDL, and you will see increased ferritin. Okay, and then you will see increased urinary catecholamines are seen, and you will see increased neuron specific linolase. So these are the laboratory manifestations. Now if you see X-ray or CT scan, on X-ray or CT scan you will see presence of stippled calcifications are seen. On IVP you will see presence of drooping lily sign is seen on IVP. This neuroblastoma will displaces the kidney. It displaces the kidney. Will displace the kidney. The neuroblastoma displaces the kidney ipsilaterally. Okay. Here, if you do, you will have to do MRI better than CT. MRI is better than CT in assessing. If you wanted to assess vascular invasion, MRI is better than CT in assessing patency. Then in assessing spinal cord involvement or compression, then MRI is better than CT in assessing bone marrow involvement. Okay, these are the important points. Then if you see the treatment is, if you do a localized neuroblastoma, if there is a localized neuroblastoma, then we can excise the tissue easily. Okay, if there is unresected neuroblastoma should be dissected. First you should do biopsy, and then you should downstage the tumor. The downstaging of tumor is done by chemotherapy plus radiotherapy plus surgery, and followed by you should do surgical resection, followed by you can do surgery. And then if there is disseminated disease, then we can do chemotherapy can be done if there is disseminated disease. Okay, so this is important point about the neuroblastoma. Now if you see, we have to, there is one classification for, not classification, there is one table for neuroblastoma which will tell us about the prognostic factors of neuroblastoma. So just 1 minute. So we will add some extra points also. So these neuroblastomas, almost 98% are sporadic, whereas 2% are familial. These neuroblastomas, among these neuroblastomas, 90% of neuroblastomas will produce phenylyl mandelic acid and homovanillic acid. They produce phenylyl mandelic acid and homovanillic acid. Now we will have to learn about the staging of the disease. So staging of neuroblastoma, if you see, you can divide it into the following stages. First we have stage 1. Stage 1 is defined as there is localized tumor with complete gross excision. You will see presence of localized tumor with complete gross excision with ipsilateral lymph nodes being negative. Then stage 2A, here you will see again localized tumor is seen with incomplete gross excision. You will see localized tumor with incomplete gross excision with lymph nodes being negative. Then we have stage 2B. Here also you will see localized tumor, but here there is ipsilateral, here lymph nodes are positive, ipsilateral lymph nodes being positive with tumor, positive for tumor. Okay, then we have stage 3. Stage 3 is unresectable tumor, and it is unilateral tumor which is infiltrating or going across the midline. It is unilateral, unresectable unilateral tumor infiltrating across the midline with or without regional lymph node involvement. This is stage 3. And what is stage 4? In stage 4 you will see dissemination to distant, you will see dissemination to distant lymph nodes. You will see dissemination to distant lymph nodes, bone marrow, liver, and then skin and other organs. Okay, then we have 4S. In 4S you will see presence of localized primary tumor, same as 1, 2A or 2B, with dissemination which is limited to skin, liver and bone marrow. Here the dissemination is limited to skin, liver and bone marrow. So this is mainly limited to infants who are less than 1 year of age. Okay, so this is about the staging of neuroblastoma. Now if you see the prognostic factors. Now if you see the prognostic factors or prognosis of neuroblastoma, so prognosis can be a favorable prognosis or it can be unfavorable prognosis. Okay, if favorable prognosis, stage of favorable prognosis is stage 1, 2A, 2B and 4S is favorable. Stage 3 and 4 is unfavorable. Age less than 18 months it is favorable prognosis, more than 18 months it is unfavorable prognosis. Then we have squamous stroma. Squamous stroma or gangliocytic differentiation. In squamous stroma or gangliocytic differentiation on histology, if this is present it is favorable prognosis, if this is absent it is unfavorable prognosis. Mitosis, or if there is mitosis or karyorrhexis index. Mitosis or karyorrhexis index less than 200 per 5000 cells it is favorable prognosis, more than 200 per 5000 cells it is unfavorable prognosis. Then again, if you see the favorable prognosis and unfavorable prognosis, then if you see DNA ploidy, if DNA ploidy then it is hyperdiploid, it is favorable prognosis. Then it is near diploid, it is unfavorable prognosis. Then we have NMIC. NMIC not amplified, it is favorable prognosis. If it is amplified, then it is unfavorable prognosis. Then we have chromosome 17q gain. it is absent favorable prognosis, present unfavorable prognosis. Chromosome 1p loss or chromosome 11q loss. All these, if they are absent, favorable prognosis; if they are present, unfavorable prognosis. Then we have TRKA expression, A for Acha, so it is present, favorable prognosis; if it is absent, unfavorable prognosis. TRKB expression, if it is absent, favorable prognosis; if it is present, unfavorable prognosis. And then we have telomere expression. Telomere expression, if it is low or absent, then it is favorable prognosis; if it is highly expressed, then that is unfavorable prognosis. Okay, so this is about the neuroblastoma prognostic factors. Now we will see treatment of neuroblastoma. Actually, we will see based on the staging. So we can divide the neuroblastoma into 3 types of risk factors. One, we have low risk disease. Okay, then we have intermediate risk disease, low risk disease, or intermediate risk disease, and then we have high risk disease, low risk disease, intermediate risk disease, and high risk disease. Okay, in low risk disease, what do you see? In low risk disease, you will see surgery. It is surgery should be done for stage 1 and 2, and observation should be done. Okay, and after surgery, more than 90% of tumors patients will recover. Then we have in intermediate risk, you should do surgery and you can do chemotherapy. Okay, and you should do radiotherapy. Chemotherapy with radiotherapy should be given. Then we have what are the drugs used for chemotherapy? And in the chemotherapy in intermediate risk stage, we can use drugs like cisplatin can be used. You can use carboplatin, can be used cisplatin or carboplatin, or you can use cyclophosphamide are the drugs which are used in chemotherapy in intermediate risk disease. You can also use drugs like etoposide and doxorubicin are used. Okay, then you have high risk disease. In high risk disease, we give high dose of, we can give high dose of chemotherapy is given in high risk disease with autologous stem cell reserve. High dose chemotherapy with autologous stem cell rescue is done for high risk disease. In the high risk disease, you do surgery, and then you do radiation, and you do 13-cis-retinoic acid. That is, you will give isotretinoin or 13-cis-retinoic acid can be given. And in this high risk disease, you have one more thing. You can also do induction chemotherapy can be done. Induction chemotherapy is done with cyclophosphamide. It is done with cyclophosphamide, topiticon. Then it is done with topiticon, doxorubicin, and vincristine, etoposide, and cisplatin. Okay, so these are the important points about neuroblastoma. Thank you for watching.